Welcome everyone to the first ever Hope on the Horizon Trials, Treatments, and Therapies for Duchenne Muscular Dystrophy. Today's webinar is made possible by a restricted educational grant awarded by Kai Pharmaceuticals and Regenex Bio with no influence on today's content. We're really pleased at Muscular Dystrophy Canada to provide this information opportunity so that really when we did our patient journey mapping on Duchenne Muscular Dystrophy, we often heard that the number one question after asking whether there's a cure is what are the trials? What are the treatments? And in the last few years, we've seen such significant growth in this area that an opportunity like this so you can receive balanced information, ask questions of top experts is really why we're putting on today's session. Today's session is available in English and in French, and in just a moment, I'll put in the chat how to access this session in French. And we have some great panelists today that will walk you through what are the best practices in terms of managing Duchenne muscular dystrophy, what are the new treatments, what are the trials, and what do they mean, what have they found out, and some research opportunities that you can participate in if you haven't already. And then we'll launch into a question and answer period where you can put in your questions in the chat or in the Q&A. So with that, I'll go ahead and stop sharing, and I'll call on Dr. Amanda Yaworski from Ottawa to go ahead and start us off by what is Duchenne and the best practices in terms of current management.
All right. Thanks so much, Mara. So yeah, as she mentioned, my name is Amanda Yaworski. I'm one of the pediatric neurologist with a neuromuscular specialist in Ottawa, Ontario. And so I'm just going to be going over really broadly what some of the best recommendations we have and what is available to really everyone or most people at this point. And so as a disclosure, I am only a neurologist. And so I think as most of us are aware, people who are living with Duchenne muscular dystrophy are managed by a huge group of people. And really neurologists or physiatrists who ever run a neuromuscular clinic are really one of those only few people. So I'm going to be talking about a lot of things that are not covered by myself on a regular basis, but that are exceptionally important for people living with DMD. So I'm going to break this down kind of based on stage of diagnosis. Obviously, that can be really different for people as sometimes they present at different stages and different ages. But usually as people are leading up to the diagnosis, for the most part, people are diagnosed when they become symptomatic. And so this can look really different for a lot of people. The most common way we see is that they might come in with proximal weakness. And so sometimes this can be delays in walking or, having some trouble going upstairs, problem getting out of a chair, things like this. Other people might present with toe walking or any other signs of real weakness. And when that's the case, we would kind of go forward with testing potentially for DMD or other conditions. There are other cases where they present more asymptomatically, and this can happen in a couple instances, one of which is people are found to have elevated liver enzymes. For whatever reason, blood work is done, maybe a patient is sick or something, and their liver enzymes are really high. And sometimes people can actually go down the path of working them up, trying to figure out what's wrong with the liver, but then eventually a CK, which is that muscle enzyme that tends to be quite elevated in Duchenne, comes back elevated, and that's when they get referred to a neuromuscular specialist to really try and see what's going on there. Other examples of that, or if somebody comes into the hospital for a different reason, for example, they have a febrile seizure or something like that, and then they're found to have an elevated CK, and that would be the same scenario. Or, of course, if there's a family history, then those patients often tend to be diagnosed before truly becoming symptomatic. These days, diagnosis is mostly based on that high CK and genetic testing. Most people to do genetic testing will start specifically with the dystrophin gene deletion or duplication. And so that's looking at those specific exons that can sometimes be missing or duplicated. Although sometimes people need to go through a little bit more advanced testing with sequencing to look for different types of mutations that might not be picked up on that initial testing. Less commonly, we have to do more invasive testing, things like nerve conductions and EMGs, which are tests that involve some shocks and little needles, or even in some patients, a muscle biopsy. But obviously, we try to avoid these when possible because they're invasive, as I mentioned. And then finally, the other carrier caveat is doing carrier screening for females. And so, definitely, if a boy is diagnosed with DMD, we would always recommend screening the mother of the child to see if she is a carrier, as well as sometimes female siblings, depending on the scenario, although that's less likely done because usually those patients do not have any muscle weakness at a young age there. And I'll talk a little bit more later about why we do that. So early in the diagnosis, shortly after, a boy is diagnosed with DMD, they'll be referred to a neuromuscular clinic. And this can be different depending on what institution you're being seen at. But as I mentioned, it's usually run by neurologists or physiatrists, depending on where you are. And it encompasses many different people. And so the main thing we're really doing when we first see you is trying to see what exactly needs do you have. Is the patient symptomatic? Do we need to do something? Is it really more just about education or screening? And so oftentimes the initial visit can be quite overwhelming because there's a lot to talk about. And so it's really just trying to get our groundwork in and see how can we best help people. Our mainstay of treatment is steroids. And so these are the only medication currently that are approved for Duchenne muscular dystrophy. And so historically, we've always had two medications, those being deflazacort and prednisone. You can see their dosing is a little bit different. Deflazacort's 0.9 milligrams per kilogram is our target, whereas prednisone is 0.75 milligrams per kilogram. A new medication, as I'm sure many of you are aware of, was very recently Health Canada approved, which is called vamorolone. This is a different type of steroid, and I think some of my colleagues are going to discuss that a little bit later on. And this is a higher dose. It's a 6 milligram per kilogram. The level of dosing, the fact that vamorolone is 6 compared to deflazacort being 0.9 does not necessarily mean it's a stronger steroid. It's just that higher dose because of the way the medication works. When people are on steroids, there's different ways we can prescribe this medication. I would say the vast majority of patients are on daily steroids. Historically, some people have used intermittent dosing of steroids. So that might be something like doing 10 days of steroids, then taking a break for 10 days, then restarting. However, as we've come to learn more about this, we really think the daily regimen is probably the most efficacious and works the best. With the one caveat being sometimes in really young patients, we'll often start high dose weekend steroids. And from what we can tell, that is equally effective as daily dosing. And the reason for doing that is really to prevent some of the side effects. Side effects with steroids can be quite a lot of issues, and these are cumulative, meaning you tend to get more side effects the longer you're on a medication. And so if we do feel like we need to start a medication like steroids early on, we'd rather limit those side effects since people will be on it for a longer point of time. Some of the main side effects you can get with steroids are increased appetite, which can, of course, lead to increased weight. It can change the distribution of fat, so it might change the way your face looks. It can cause a lot of irritability, problem sleeping, high blood pressure. It has a lot of effect on bones. And so, as I mentioned, there are a lot of side effects that we do see. Because of this, we don't recommend using steroids in people before we see any evidence of weakness. So if you have a scenario where someone is diagnosed before they're symptomatic, we would not usually start them on steroids at this point. When people are no longer walking, when that becomes a bigger issue, then some people will kind of change the way they prescribe steroids. But we do know, if possible, maintaining some degree of steroid is important because it helps preserve your upper arm strength. It helps prevent scoliosis, which is the curve that can happen sometimes in the spine. And it can also delay some of the breathing and the heart problems that we do see. So other things that happen early on when you're diagnosed is a meeting with endocrinology. This is really important for stress dosing as well as looking at bone health. We tell all of our patients at onset, really, they should be started on vitamin D supplementation, and having a good amount of calcium intake is really important. Stress dosing is something that we do because our body naturally makes steroid. But when we give somebody steroid to take, our body gets a little bit lazy and forgets how to make the steroid on its own. And so when your body goes under a stressful situation, that can be something like being sick or having a surgery, you need to make more steroid. And if your body isn't doing that naturally, that can lead to a significant problem. And so because of this, then we have to give extra steroid to really prevent this from happening. So things where you would need stress dosing would be any kind of significant illness. So if someone has a fever or any really cold-like symptoms that are going to prevent you from doing what you would normally do, going to school, going to work, etc. Any really unexplained fatigue or lethargy, a planned medical procedure, so a surgery or a dental extraction, and a broken bone. These would be kind of the most common cases where we would need it. And stress dosing is different in each institution and depending on what steroid regimen you're on. But in general, we would recommend continuing with your regular steroid, whether that be deflazacort, prednisone, or vamorolone. And then in addition, you would have to take this extra type of steroid, which is called hydrocortisone. And you can see there that the dose really varies depending on institution, but it's usually something that needs to be given orally 2 to 3 times a day. If you're really sick and can't keep that down, there's lots of vomiting, then you actually end up needing intramuscular, so an injection of hydrocortisone into the muscle. And the reason this is so important is because if it truly progresses all the way to adrenal insufficiency, that can be really dangerous. And I've listed some of the symptoms here, headache, nausea, vomiting, pain, decreased level of consciousness. This is all really vague symptoms, and so it can be really difficult to identify. So this is why we all tend to err on the side of caution when recommending stress dosing for people. Other things that happen early on in the diagnosis is we tend to get a baseline cardiac assessment quite early. And so through this, we do an ECG and an echocardiogram. So an ECG is where we put the little stickers on. We measure the electricity or the rhythm within the heart. And then an echocardiogram is that ultrasound where we get a nice picture of the heart. We can see the function. At the beginning, sometimes respirology is involved, but oftentimes they're not because we really know there's usually not any issues clinically. And then the rehabilitation is a really big piece of this. And so you'll see a physiatrist potentially, you might see a physical therapist, occupational therapist, and there's a couple main reasons for this. One of which is the importance of stretching and really doing passive range of motion. So moving the limbs that are weaker and might not move in the full range that we would normally expect. And so this is important because if a limb is not moved that way, the joint can actually get stuck, which is called a contracture. And that can really make moving it difficult and often needs a surgical correction if anything. And so we try and avoid that as much as possible. The other thing that's really important from a rehab perspective is standardized testing. And so depending on what stage of DMD people are in, whether they're walking or not walking, there's many different tests we do. I've listed some of them, more common ones here. You might have heard of some of them, the NSAA, the Hammersmith, the Brooks Upper Extremity Scale. And all of these are just different ways for us to get an objective measurement of how things are progressing. And it's really important from us just as, healthcare practitioners, but it's also increasingly important as there's more drugs approved that may be more expensive that we can actually prove that the medication is working. They also do a lot of equipment needs, which I'm going to talk about a little bit later. The last thing that we tend to bring up early within diagnosis is the psychosocial component. And I have to say, as neurologists, we're probably quite bad at this. So this is really something that we will often rely on, primary care providers, pediatricians, or families to really do a lot of advocating for. And so anyone who has a chronic medical condition should really be undergoing mental health screening quite regularly. And then in addition, we know that Duchenne, there's dystrophin that's expressed in the brain. And so sometimes there can be higher rates of neurodevelopmental disorders. So this might be things that can present as learning disabilities, attention problems. And so it's really important to screen for these and treat them appropriately. The next stage I'm going to talk about is, okay, you've been diagnosed, you're still walking, but walking is getting harder. You've got more limitations. So at this point, we would continue treating with steroids. Endocrinology continues to be involved with stress dosing, your bone health. They might start looking for vertebral fractures. Those are little fractures within the spine that I'll talk about a little bit later. And at this point, from a heart perspective, they're going to be making sure you're monitoring annually, and they might consider starting a medication. And so the way they tend to monitor patients is continuing with that ECG and echocardiogram that I mentioned. But oftentimes they'll start to do something called a cardiac MRI. So this is just a much more detailed examination of the heart. The reason we don't do it right at onset is because we know people don't, for the most part, don't have problems with their heart really early. And it's a test that you really need to lay super still for. And so it's something that just functionally does not make sense to do really early on. Um, the medication that cardiologists usually start are something called ACE inhibitors, so angiotensin converting enzyme inhibitors, or ARBs, which is angiotensin receptor blockers, usually the first kind of big categories of medication they will use. And there's a little bit of discrepancy, probably depending on what center you go to, whether it's best to start these medications when people are still asymptomatic from a cardiac perspective, meaning their heart looks great, they're not having problems, compared to waiting until we start to see some of those changes on the echocardiogram or the ECG. I would say regardless whether you're on the side of starting asymptomatic versus symptomatic, most people like to have these started by the time boys are about 10 years old. And then if you're a female carrier, this is when that's really important to know because you'll be having baseline cardiac assessments usually every couple of years. At the stage, at the late ambulatory stage, if respirology has not been involved, they would now become involved. And so usually at this point, again, there's not a ton of breathing issues, but we would definitely start to at least do screening of pulmonary function tests. So this would involve boys, blowing into tubes, and we'd be able to see, how much lung volume, how much can they expand their lungs, how much force are they able to provide when they're doing that. And this can help tell us, are they needing help with breathing or not? Rehab continues to be involved with everything I mentioned previously, and then you might start to see orthopedic surgery, or your neurologist or physiatrist might start to talk about monitoring for scoliosis, as I mentioned, that curve in the back. And people do this differently. This could either be through visual inspection, so actually looking at the spine, or through getting an X-ray. As we then get into the non-ambulatory phase, so this might be when a boy, is mostly wheelchair bound, but is still able to walk really short distances, sorry. For the most part, people will continue on the same dose of steroids that they've been on, but we definitely start to see a lot more involvement within endocrinology. So they still continue to do all the same things as they've done before, but there's lots of other added factors that come in here. So we know steroids can affect growth. This is not something that would only be done in a late ambulatory. Growth is, of course, something we would be monitoring right from the onset, but they would be doing regular measurements of height standing, or sometimes people will do a measurement of part of the arm to get a good sense of height. I say here consideration of growth hormone. I would say this is definitely not something that's commonly done in boys who have Duchenne muscular dystrophy. And the reason for that is because there's a lot of worry that growth hormone might actually have a negative effect on the muscle and might make it potentially weaken it. In addition, we know the taller you are, the harder it is to walk, the more weight you're kind of putting on your muscles. So most patients do not end up going on growth hormone for the most part. But of course, this is something that should be discussed with your endocrinologist. Around this stage is when we can start to see issues with puberty. So for most people, if there's no signs of puberty clinically, so meaning, when you're looking at a patient, are they sweating? Do they have underarm hair, things like this? By the age of 14, that's when we'll start to do more tests. Some people do it a little bit earlier. And so there's blood tests that we can do. Sometimes we'll take a special type of picture to look at the bone age. And at this point is when we would start to consider testosterone replacement to really induce that puberty. As I mentioned, they continue to be involved for that adrenal insufficiency or stress hormones. And then weight management is also a big one. Sometimes this can also be initiated by your neurologist or physiatrist, with more simple medications such as metformin, which can help suppress appetite. But there's lots of new medications that are come out that tend to be only prescribed by endocrinologists that really help to suppress appetite through different mechanisms. And so this is always something that should be considered. And then bone health becomes a bigger deal at this point. And so definitely monitoring for vertebral fractures with yearly spine x-rays, because sometimes those fractures can actually be asymptomatic. And this is something that tends to change management. There's also some blood work they can do. They'll do bone scans, called a DEXA scan on a regular basis. And then they might actually start an IV bisphosphonate therapy once there's signs of bone fragility, which is usually a fracture seen within the vertebrae. Otherwise, if cardiology has not yet started a medication, they would likely start it at this point. And then respirology tends to become more involved with more assessments, because this is around the age when we can start to see more breathing problems. And so, as I mentioned, the pulmonary function tests usually start when they're younger. We usually don't do it before the age of 5 or 6 because they just need to cooperate, and that can be really difficult at young ages. And then people will also consider doing sleep studies looking for any signs of obstructive sleep apnea or hypoventilation, meaning you're not kind of filling your lungs as much while you're sleeping. There's also lots of different mechanisms they can use to really help exercise your lungs and keep them healthy. And so they can do lung volume recruitment or assisted cough, which is really important when people are sick and they might have a hard time really clearing mucus and things like that from their lungs. And these are usually started based on those pulmonary function tests. Assisted ventilation comes in around this time, most often at night first. So people might need help breathing at night for a number of different reasons. As I mentioned, they might have the sleep apnea with really bad snoring, or it could be because of hypoventilation. And then daytime ventilation is not usually required until a little bit later on. And then routine immunizations, although a respirologist likely wouldn't do this. Again, this is really important for family doctors or pediatricians. We would always recommend routine immunizations and definitely routine flu shots to help keep people safe. Otherwise, rehab here will continue to do the testing, but definitely getting more involvement with equipment. So whether that be bracing or wheelchairs or lifts to help with transfers, there's many things that they would do there. And then continuing to monitor for scoliosis by our orthopedic team or ourselves. And at this point, they might actually start talking about a transition to adult care. So of course, at this point, a pediatric team would continue to follow them. But we may move on to just talking about this because it can take quite a while sometimes to do. Otherwise, when, we've now passed, people aren't walking anymore, they're really in the wheelchair all the time. Things are relatively the same. Sometimes, as I mentioned, with steroids, people might consider decreasing the dose depending on how bad the side effects are. Otherwise, endocrinology, cardiology, respirology, rehab are really all doing the same kind of monitoring. Orthopedics might talk about potentially doing a surgical intervention for scoliosis. And this really depends on the degree of the curve, how progressive it is. We know with steroids, we really have changed the natural history of the curve. And so most people now don't rely on a number of degrees of curvature, but instead the actual progression. And so sometimes this is done when people are no longer ambulatory, although there are some people who think it's actually done a little bit better early on. And so that's a discussion, again, that should be done with your orthopedic surgeon. And then, of course, treating fractures appropriately. So as I mentioned, unfortunately, with the steroids, we cause a lot of bone issues. And so you're often going to be seeing an orthopedic surgeon if you were to develop a fracture. We want to make sure that's managed correctly. And then finally, the transition to adulthood is something that is super important. And our social work colleagues are really helpful in this case. This can be really scary for people, having to switch providers completely. There's a lot of things to think about that we don't think about on a day-to-day basis. So, what's going to happen with housing? Am I going to need to, hire someone to help take care of me? Am I going to, what am I going to do for work? Am I going to be on the same healthcare plan or does that need to change? And so there's really a lot of things that are important to go through. And that's why we tend to try and start having those conversations early. So it's not a big surprise, when you're 17 or close to transitioning to discuss. And that's all I've got for you. I've listed some resources here that are super helpful for people with to go through some of these guidelines in a little bit more detail. And I'm happy to take questions maybe at the end, Kamara, if that works. Yeah. Okay.
That'd be great. Wonderful. Thank you. We'll transition over to Dr. McMillan now, who will be sharing some information on the treatments.
Fantastic. Thank you very much, Homira. I'm just trying to share my screen and
Looks good. Just on full screen. It
perfect.
likely will show up in a minute or a moment.
Excellent. Is that okay
Perfect.
there?
Great.
Fantastic. So I'm also a pediatric neurologist, neuromuscular specialist. I'm colleagues with Dr. Yaworski in Ottawa, and we're going to be talking about some really quite impactful results that are emerging from clinical trials and additional clinical trials that will be coming in the very near future. And Dr. Nguyen, who's coming after me, will be talking about some quite impressive recent advances with some therapies that we now have as treatment options. So one slide's really important just to remind everybody about the job of dystrophin, and really what it is, it's a shock absorber. So if we see that those fibers that are contracting, those orange rods, that's what really gives muscle its power. And the pink dystrophin molecule helps as a shock absorber so that contractile force of the muscle doesn't end up tearing that ladder-like structure above it. And it's a bit like driving around in Canada in the spring if we don't have dystrophin, because that contractile force from our muscle fibers can cause the muscle fibers to tear. They have the ability to repair themselves, but only so many times, only to a point. And that's when we start to see the weakness progress. So we want to try to help do what we can to correct that problem with the dystrophin, or help in a downstream manner with other ways to help protect the muscle. There's a number of approved therapies for DMD. I think we are all very familiar that our colleagues and our patients in the United States on the left have much more access to these therapies than we do on the right in Canada. We did see our first disease-modifying therapy approved this year, which is vamorolone, and we do have access to deflazacort, as I think all of you know, through special access, but we don't have access to the same number that some other countries and jurisdictions do. Now, clinical trials, Canada does hit, I would say, above its weight with regards to making clinical trials available for patients and families that are interested in participating in them. Each of these different boxes represents a different clinical trial that's run by a different sponsor. The Canadian flag, of course, are trials that are being run in Canada or have recently been run in Canada. Some of them with the little stoplights have stopped, the two on the left, because of either lack of therapy or some safety issues. Pfizer trial was not shown to be efficacious, so it was not proceeding beyond that. And one of the Sarepta's non-ambulatory gene therapy trials is on pause right now, and we'll talk about that just a little bit more. I like to break these up into three big categories, which really helps me to be able to understand the main differences and to be able to communicate that when I'm speaking to patients and families. So the top left are the exon skipping therapies, and I'm going to describe to you what that means. On the top right, we're seeing the gene replacement therapies. And then the ones that are at the bottom, and the bottom left, bottom right, are the small molecule and biological agents. All of these being targets to try to help people with Duchenne muscular dystrophy. Now, the three different categories that I described to you, they really work in very different ways. So the gene therapies on the left help to restore dystrophin. Now, that's similar to the exon skipping therapies in the middle. The gene therapies are suitable for most mutations, but there's some exclusions for people that have deletions that involve exon 8 to 11 typically, and that's because of a safety issue. Gene replacements have been shown in the phase 1 studies to effectively replace fairly large amounts of the mini dystrophin in the membrane of the muscle. But really the question for the gene replacement therapies as they continue to move forward in clinical trials is that impressive restoration of that mini dystrophin, does that translate into meaningful clinical change? And that's the question mark that's really driving these phase 2 and phase 3 trials that I'm going to talk about. Exon skipping therapies, they help to restore dystrophin as well. They're only suitable for people with specific DMD deletions right now. They help to replace a smaller amount of a more normal appearing dystrophin. And I'll explain to you what I mean by that. There's also the small molecules in the biologics. They do not replace dystrophin. They help the muscle in other ways. And Dr. Nguyen is going to talk about this in quite a bit of detail later. These are suitable for any DMD mutations. The gene replacement therapies help to replace a smaller form of the DNA. The exon skipping therapies work on something called RNA, and I'll explain to you what that is in the next slide. And then the small molecules will help to work on various proteins. So what is DNA, RNA, and protein? So the DNA is our master copy. It's a little bit like just below it, this master blueprint that's really precious, and it's kept in head office. We have one copy of DNA for each of our cells. Now, RNA are sort of the equivalent of photocopies that are sent out of the nucleus into the rest of the cell that eventually are going to be getting made into proteins. So those RNA molecules are really a bit like the blueprint copies that are sent out to the construction site so that the people that are actually working there know what to build. And the proteins are like the construction workers that actually carry out the day-to-day work. They do the heavy lifting. So gene therapy is working on the left, exon skipping is working on the RNA, and then those other small molecules are really helping with proteins in one way or another. So we're going to start talking about the exon skipping therapies first. Now, this is a figure of what the dystrophin gene looks like. You can kind of picture it as 79 different puzzle pieces. Now, we call those exons in medicine. And the DNA, when it gets photocopied, they need to have 79 different puzzle pieces there for that normal dystrophin to be made. But what happens if they're not all there? So this is an individual who has an exon 50 deletion. And you can see that right near the center where there's no puzzle piece 50. Now, the two ends, number 49 and number 51, they cannot fit together. So that RNA, that photocopy, cannot make a normal protein. We see no dystrophin in an individual who has Duchenne muscular dystrophy who has an exon 50 deletion. Exon skipping therapy in this case is using an exon 51 skipping approach. So it doesn't change the fact that this individual is missing puzzle piece number 50, but now the exon skipping therapy is going to silence the expression of 51. That's what that little comb is that's sitting above it. And now the little puzzle pieces 49 and 52 can fit together. So as a result of that, the RNA is now able to make proteins. It's not completely normal. It's a little smaller than it should. It might be a little bit less impressive in terms of its function, but it's able to do the part job that dystrophin should do. And essentially, if we can allow this to occur in enough quantity, it can allow for an individual with DMD to potentially be converted into having a Becker muscular dystrophy-like clinical presentation, a much, much, much milder disease. And just as that example again of somebody who has a mutation that's amenable to exon 51 skipping, it's not just an exon 50 that's missing. It could be many different deletions there that potentially could respond to an exon 51 skipping drug. Now, clinically, There's a number of these that have already been approved in the United States. So there's an exon 51 skipping therapy called eteplirsen, exon 45 skipping therapy called casimersen, and there's an exon 53 skipping therapy called golodirsen or vitolarsen. And these have been estimated to benefit just under 30% of all individuals who have DMD. Theoretically, though, if we were able to make exon skipping that could be manufactured for all different types of deletions, and potentially, if some of the preclinical work that's being done continues to move forward and look promising, might even help some individuals with duplications. There's some work that's being done on the preclinical side looking at double exon skipping. So if you were able to skip the piece that's duplicated and then skip the one beside it to potentially bring it back in frame, then that, for example, would be an effective therapy if we were able to have that happen in a high enough efficiency. One of the problems with the exon skipping therapies that we just talked about in the other slide, the ones that are approved in the United States, is they're what we call naked antisense oligonucleotides, or naked exon skippers. There's another generation of exon skippers that are currently in clinical trial that have much better penetration into the muscle. And they use different technologies to do that. So what we see here is this little ladder-like structure, this little pink or blue ladder is the antisense oligonucleotide, that little comb I showed you. The first technology is to bind part of an antibody, in this case, one that would normally bind to the transferrin or responsible for carrying iron in the body, to help that antisense oligonucleotide get to where it needs to be. There's another strategy using an endosomal escape vehicle that helps it to get out of the sort of the garbage bags within the cell to give it a better likelihood of getting to where it needs to be. And then this last strategy, which unfortunately hasn't proven to be as effective, is using a protein-rich tag on the antisense oligonucleotide, the exon skipper, again, to try to get it in better quantities. This has shown some benefits, but the concentrations of this that have been required have needed to be so high that it started to cause some complications, including the potential for there being some kidney injury. One of the promising therapies with an exon skipper that's bound to that partial antibody is from a company called Dyne Therapeutics. Now, they've run a very early phase 1/2 clinical trial. The study itself at the 20 milligram per kilogram dose showed an increase in dystrophin expression of 8.72%. Now, just as a comparison, those naked exon skippers that I talked about before, the dystrophin expression we see with them is about 0.5%. So that's a significant change compared to what had been available previously. This also appears to be safe. There was one boy that had some problems with low platelets, low white blood cells that was transient and then recovered. But this one does not seem to have the renal complications that have been noted with the protein-bound exon skippers. This also showed some meaningful improvements in some of the motor outcome measures, but we have to be very, very cautious and acknowledge that this was a small study with very few patients, and it will be studied in the next phase of clinical trials, phase 2/3, with a larger number of patients to be able to see if there is demonstrable improvement in the muscle function of those patients in a properly powered study. But that's very promising results. Another very promising study is from a company called Avidity, which has used an exon skipper for people who have an exon 44 skip amenable deletion. And they found a 25% increase in dystrophin with their molecule. They also showed an impressive, here in blue, drop in the serum CK compared to, in gray, those people in the trial that received the placebo. So a much more significant increase in dystrophin and a decrease in CK. Again, very promising, but we have to acknowledge this is an early study and it needs to be replicated in larger numbers before we get too excited about this. There's another company called Wave Therapeutics that has a trial going on right now, and that uses a different stereochemistry, which is a way to also be able to gain better access into the cells. So the DNA, the gene replacement therapies, let's talk about replacing that master blueprint that has the abnormality in it. Now, if we think back to that dystrophin molecule, it's a huge gene with those 79 different puzzle pieces. And there's no way we could package all of that gene up into a little viral vector, which is basically just a vehicle to get it where it needs to be. So as a result of that, we learned from some families, which we so often do. And this was a family that lived in the United Kingdom, and they had a very large deletion in their DMD gene. They were actually missing puzzle pieces number 17 all the way to puzzle piece number 53. So that's almost half of the dystrophin gene was missing. But if you see here, puzzle piece number 16 can fit together with puzzle piece 54. And as a result of that, the people that the males in the family that had symptoms didn't develop any symptoms until they were in their 30s, and they were able to walk well into their 60s. So that started to get people thinking, maybe we don't need to give all of the dystrophin gene. Maybe we can get away with just giving part of it. And that's the basis for that's the basis for the gene therapy clinical trials that are going on now. So if we look at the very top here, all of these boxes, this represents what the normal dystrophin molecule would look like. And then each of the different companies here, Sarepta and Roche, Solid Biosciences, Genethon, Regenx Bio, they have chosen different parts of the dystrophin gene that they feel are the most important to potentially be able to give the best function if it gets into the cells. There's significant differences between them. So it's a mistake to think of all gene therapies being the same. Number one, they use different vehicles to be able to deliver that gene therapy back to the muscle cells. Some of them use an adeno-associated virus number 9, some number 8, the Sarepta one that's approved in the United States, and RH74. They have different promoters that help to turn it on to do its job. They have different parts that I showed you in the other slide. And then one of the companies, which I'll talk about a little bit later, offers prophylactic immunosuppression, which is different from what has been done with the other companies before that. Now, many of you have heard from the trials that Sarepta ran in the United States, was that the trial that was done using their product, which is called Delastystrogene moxeparvovec, it's a real tongue twister, it didn't meet its primary endpoint. So if you see that at the very top here in yellow, when there's a box like this that crosses this line at 0, statistically, that just means it didn't cross its endpoint. It didn't reach significance. And that's a big deal for study design, because at first glance, one might say, oh, maybe the drug's not effective. But what it did show, and this was really the basis for it getting approved in the United States, is it met a number of different secondary endpoints. These are endpoints by which other drugs, including some of the ones that Dr. Nguyen will talk about later, did get regulatory approval for. So is it a question where it wasn't effective, or is it a question where they maybe didn't study the right thing? And that's been a real head scratcher, because if we look at that North Star ambulatory assessment, which looks at things like how fast can you walk 10 meters, how fast can you get up from the floor, can you rise on your toes, we see between the ages of birth up to about 6.3 years of age, there's a gain. And then we start to see a very slow decline that becomes more constant from about the age of 8 years old onwards. You can see right here, this is the age that was used in that study, and it perfectly straddled patients that were improving, patients that were declining, and the rate of change was very low there, which really does raise the question about whether it was the right study, the right test to look at in that population at that age in the numbers they chose to evaluate. They also pointed to some of the early phase 1 studies. Again, these are the very early safety studies. Each of these different points represents a different patient. So the different colors are all different patients. The different dots are the different times that they were assessed. And we can see, if we look at the shaded lines, these are what the natural history would show without treatment for people that were getting gene therapy. Whereas the individuals that were treated in that phase 1 study have remained relatively stable, or this one's decreased a bit and then been stable, a big change from the natural history. Again, we have to be careful not to overinterpret this, but I think there's a number of conflicting data points on this, and it's not as simple as just saying that the primary endpoint was met, it's not effective. there's questions still to be answered. When they looked at it at 2 years and they compared it to natural history data, there was an improvement in the North Star Ambulatory Assessment in their group compared to what people would have been predicted to do without treatment. And the time to rise was not as fast in those that received the gene therapy compared to those that didn't, and the 10-meter walk test showed a difference as well. Potential side effects are something to consider with gene replacement therapy. And what I would say in general terms is that there's about a 1% risk with gene therapy for DMD of having a more severe adverse event. And there have been three patients actually over the last 18 months that have been treated with Sarepta's gene replacement product and have died of complications of liver failure. And that's something that's important to keep in mind. Especially as doctors, we don't want to do any harm. We want to be monitoring people, caring for them, helping them to get better. We have seen here that there's different complications that can arise at different times. In the first few weeks afterwards, we often see vomiting, nausea, and the potential for problems with platelets that make blood clots or kidneys. And then later on, after a few weeks, there's a greater potential for there being problems with the liver or even the heart. All of the patients are treated with steroids, very high dose steroids like prednisone 60 milligrams in the months following gene therapy. But one of the questions is that enough? And that's the basis by this one company called REGENXBIO that's using a gene replacement therapy. And they have, in addition to the corticosteroids that are being treated, they have two additional immunosuppression agents that they feel really significantly improve the safety profile. The results from their early study, this is their phase 1 study, showed, and again, these numbers are small. There's only 3 patients here in the blue line that were treated, some significant improvement in the time to stand compared to age-matched controls. 10-meter walk run, there was some improvement there, again, compared to the controls. Time to climb 4 stairs compared to controls, and then that North Star Ambulatory Assessment, that 17-item test result. So I do think that the additional immunosuppression does seem to be offering some improved safety profile, because the patients that have been treated in the phase 1 study and some other studies that they've done have not had a rise in their serum transaminase levels. But the goal of the phase 2/3 study that's being run right now with REGENXBIO, and they're about halfway through their recruitment for their clinical trial, is does this offer benefit to the muscle? Does this offer benefit to function, improved walking for longer? And that's really the emphasis of that trial. Another company called Solid Biosciences is also beginning another phase 2, phase 3 clinical trial, and there will be Canadian sites for that. It uses, again, a different gene replacement therapy that has the aim of improving both muscle transduction and skeletal muscle function in the arms and legs, but also cardiac muscle. And in addition to that, decreasing liver targeting through their special viral vector that they've created. The trial that's going on now, there'll be multiple sites around the world. The trial that had already been won, this phase 1/2 study, did show that there was very good expression in the muscle. So they're seeing improvement in the microdystrophin levels of even 110% of normal. But the question is, with these gene therapies, is we're seeing very impressive translation of these microdystrophins, but is that microdystrophin translating to clinical improvement? Now, I mentioned to you, again, they're all a little different. This would be a dystrophin molecule at the top. These are the different constructs from the different companies. And at the very bottom here are patients that have had very severe side effects that are associated with them. And one thing that was found in common between all of these patients here in this salmon-colored bars and the different gene therapy constructs is they all had deletions between exon 8 and 11. And that's the reason why those individuals are not included in clinical trials at this time, purely for safety reasons. So I'm going to stop here and turn things over to Dr. Nguyen, who will take us through the home stretch, and then we should have lots of time for questions.
It looks great.
Thank you. So I have to start by thanking Humira for the great invitation. It's always a pleasure to be here, especially when I'm in such good company as my colleagues Hugh, Craig, and Amanda. So there is some overlap between Dr. McMillan's presentation and mine, although we did try to meet up and sort things out. So I'm going to be focusing more on drug mechanisms. So the problem, as we've already mentioned, in Duchenne muscular dystrophy is the DMD gene mutation or pathogenic variant in the DNA, which leads to a RNA that is unstable and degraded and absence of protein, dystrophin protein production. So I will go quickly on this because Dr. McMillan already mentioned this. Dystrophin has a major mechanical stress structural role to maintain muscle fiber and muscle membrane integrity with each muscular contraction. And this repeated damage and insufficient repair of the muscle will lead to these hyperactive inflammatory pathways that are overactive and overstimulated, and that are also part of the pathophysiology of Duchenne muscular dystrophy. So as Amanda has previously mentioned, the standard of care for Duchenne muscular dystrophy right now in 2025 remains corticosteroids. Dr. McMillan was kind enough to fill me in on the original study that really led to steroids becoming the standard of care since the 1990s in Duchenne muscular dystrophy. So that you can see it was published in 1989 in the New England Journal of Medicine. And Dr. McMillan was also very kind to share with me some of these slides. So obviously, we're using these as standard of care because the benefit in Duchenne muscular dystrophy has been well proven since 1989 and even before that. So the pros of using corticosteroids in Duchenne is that it delays loss of ambulation around 2 to 3 years. It improves pulmonary health. It reduces the onset and the progression of scoliosis. It's extremely rare for a Duchenne muscular dystrophy individual to require scoliosis surgery when prednisone or deflazacort has been prescribed adequately. And it also delays the need for cardiomyopathy treatment, although it does come with some metabolic side effects, which are not the greatest for the heart. So there's a balance there as well. In terms of cons, a lot of families, as you know, will tell us that it slows growth significantly, so growth stunting. The one side effect that, as a pediatric neurologist in our multidisciplinary neuromuscular clinic, we really have to work hard with the boys, the teenagers, and the families is how to manage that increased weight gain that occurs to the majority of individuals on daily corticosteroids. There's also a significant risk to bone health and also behavioral issues that can lead to having to adjust the dose. So that's why we were all very enthusiastic when the first approval of vamorolone in DMD happened just at the beginning of last month. So vamorolone, since I'm the one focusing on drug mechanism, it's a great story that I all encourage you to read because it was actually developed through an international public-private partnership, which makes it a wonderful story. And it's a first-in-class dissociative steroidal anti-inflammatory drugs. So I've just shown you that inflammatory pathways tend to be hyperactive in Duchenne muscular dystrophy. So that's why the anti-inflammatory effect of steroids and vamorolone is very interesting. However, it's dissociative, meaning that it will retain this anti-inflammatory effect, but it will hopefully have this more favorable overall side effect profile. How does it do it? It targets the NF-kappa B pathway, which is an important inflammatory pathway, and this will help stabilize muscle membranes. All genotypes, all DMD pathogenic variant or mutation are eligible for vamorolone, and it's given orally, as I'm sure many of you know already. So as we've already mentioned, a big milestone last month. And these are, again, some slides from Dr. McMillan showing the very frequent, so it's shown in studies that boys and men with Duchenne muscular dystrophy have a height that's, as a general population, a bit lower than the general population. However, this is really exacerbated to a very high level by giving corticosteroids, as you can see in this growth chart here, and also the significant weight gain, as all the Duchenne community knows very well. Vamorolone is very different. As you can see, there's no appreciable effect upon linear growth. And there is often weight gain with vamorolone, so not a significant difference from our traditional corticosteroids. However, if this weight gain is compensated by a growth stunting that is much less, then it's a different mechanistic effect on the body. How will this affect walking long-term or scoliosis long-term? We don't have the long-term data to really know the answer to these questions yet. With vamorolone, what has been shown in clinical trials so far is also a very favorable bone turnover marker, and it's also been associated with a decreased risk of vertebral fractures, which is something that is very frequent with chronic use of our traditional corticosteroids. So far, the studies of vamorolone have also shown a better behavioral side effect profile, meaning less behavioral side effect profile, obviously, as you can see in this graph here, with this significant reduction. So what I've been, well, not just me, obviously, but the whole team at Marie-Enfant and Saint-Justine, when discussing this with families, is that compared to our traditional corticosteroids, prednisone and deflazacort, what we know about vamorolone so far is that the motor benefits of muscle seems to be quite similar up to about 2.5 years. However, long-term data is not available yet. Linear growth, so height, is less affected than with our traditional steroids. Weight gain is not no longer of a concern. It's still a concern that has to be addressed. Fractures can still happen, but there's less vertebral fractures of the spine. There's less behavioral problems as well. However, I think Amanda already alluded to this. Everyone who's on chronic corticosteroids or vamorolone have adrenal suppression and are at risk of adrenal insufficiency. However, this seems to be exacerbated when on vamorolone compared to our traditional steroids. And therefore, when using vamorolone, corticosteroids stress coverage for when these individuals with Duchenne have either moderate or severe disease, including infections with fever or fractures or surgery, they really need to have this stress coverage prescribed. And that's what we do for all of our patients on vamorolone so far. Very important. And we also, and Muscular Dystrophy Canada also recommends that all of these individuals have a medical information bracelet to mention this. And also there are many things, because vamorolone has not been used long-term, that we're still looking to find out with time. So just to show you the different pathways that are impacted by the traditional steroids compared to vamorolone. So vamorolone acts on the NF-kappa B pathway that we spoke about, but doesn't act on other pathways, including pathways that lead to some undesired side effects of corticosteroids. Again, this is just to drive home the importance of stress coverage. This is the key study of vamorolone compared to placebo and compared to prednisone. So in the graph, you can see that already it's quite good, because when Duchenne muscular dystrophy is a disorder that takes often months to see change, clinical change, but it's very encouraging to know that already in this study at 24 weeks, there was a clear difference between the placebo group and the high dose. So that's the dose that has been approved by Health Canada, vamorolone group. And that is a motor measure that showed clear benefit in the high dose group. I wanted to speak a bit more, although Hugh already mentioned this very well, about the mechanism of how exon skipping drugs function. So I've already shown you this. Exon skipping acts on the RNA level. And this is actually the slides that my students, medical students and residents enjoyed the most. So I wanted to show you this. So when we talk about how the pieces of the puzzle go together, Hugh mentioned this. What we're talking about is actually the reading frame rule. So let's take this fun sentence that has many three-letter words. The fat cat ate the rat. So some mutations will switch just one letter, but if this letter is switched at the correct place, what happens is that the sentence changes in meaning a little, but it's still readable. Again, some mutations might insert a three-letter word. If it's inserted at the correct place, the puzzle can still be read, the sentence can still be read. You can have a deletion of a few letters, multiples of 3. The sentence has changed a bit in its meaning, but it's still readable. Here you have a deletion. We've removed only one letter. However, this is gibberish now. So it means the RNA is unstable. It will be degraded and there will be no protein production here. Same thing here. We've removed many letters and made the sentence unstable or unreadable. And you can see the possibilities are endless, but there's two big groups of mutations that can come and affect the reading frame. Some that the sentence is still readable, meaning you respect the reading frame. So you've changed the sentence, so the protein is not exactly the same, but there's still a bit of protein. These mutations are 90% of the time associated with Becker muscular dystrophy. What I mean is the reading frame rule applies around 90% of the time. There are 10% approximately that are exceptions that won't follow this rule. However, if you have a mutation that makes your RNA completely unreadable, unstable, then no protein will be produced and you have the more severe Duchenne muscular dystrophy. The logic behind exon skipping, like Hugh has shown very, very well, is to use these small molecules called antisense oligonucleotides to skip over certain exons. Like we're missing exon 50, and missing exon 50 gives rise to a mutation that does not respect the reading frame that's associated with Duchenne. But we're using small molecules to skip over exon 51 and glue 49 to 52 and basically restore or reestablish the reading frame. And one point that I'm also mentioning often to patients and families, it means if this therapy is working very, very well, you don't one day to the next transform a Duchenne individual into a Becker individual, because your Becker individual has been producing their smaller, slightly different proteins since they were born. So that's also something that I like to explain when discussing these clinical trials. However, it's still very important when we think about future approach as combination treatments and trying to improve everything that we can improve, obviously. Hugh has spoken very well and clearly about gene therapy. So just to, again, mention the mechanistic side of it. So most of the gene therapies that are currently in trial or approved in other jurisdictions use viral vectors such as the AAV or adeno-associated virus to come and deliver a mini version of the dystrophin gene. Why a mini version? It's really because it doesn't fit the entire gene of Duchenne muscular dystrophy. It's actually the biggest gene in the human body. So that's why we have to use these micro or mini version. Most of the ones that are currently in study are micro dystrophin. These AAV virus don't produce a disease in humans. However, they can elicit an immune response. And also, in addition to the immune response to the virus, like Hugh correctly and clearly explained, there is also an immune response to the dystrophin that is not normally produced by individuals with Duchenne muscular dystrophy. And that can lead to significant side effects. So immune response, again, against the AAV, but also the transgene epitope, so parts of the mini dystrophin or microdystrophin protein. Another very interesting new drug currently studied and currently approved in the United States that we'd like to touch upon is givinostat. So givinostat, if you read about the type of molecule that it is, it's a histone deacetylase inhibitor. So how can I say this more clearly? Many things with our genes are controlled by other genes that will increase or decrease the expression of these genes. So by inhibiting histone deacetylase, givinostat changes the expression of many genes, and ultimately this appears to enhance muscle repair. And because this does not act through dystrophin, it's acting on another part of the pathophysiology of Duchenne muscular dystrophy. So it can be potentially synergistic with other mechanisms of drugs, including corticosteroids. It's taken by mouse. All mutations can be eligible for givinostat. And the way that it acts, it decreases inflammation, it decreases fibrosis and fat infiltration inside the muscle. And it also promotes satellite cell activation. Satellite cells, I'll show you more, a few more slides on this, but they are crucial to the repair of muscle fibers, and it also enhances fiber regeneration. So this is the EPIDIS trial, which was the key trial that led to givinostat being approved in the US. It's a randomized double-blind placebo-controlled trial involving 179 individuals with Duchenne muscular dystrophy who were on stable corticosteroid regimen, who were walkers, who were more than 6-year-old. And because of some safety signals, so an analysis during the study, the dose had to be reduced. Some of those side effects, including effects on blood elements, including low platelets, which goes with a increased risk of bleeding. And at the end of the study, at 72 weeks, what they saw is the placebo group and the givinostat group, both groups had a decline in their speed to climb 4 stairs. However, the decline was significantly smaller in the group treated with givinostat than the placebo group. Additionally, they also had data from MRI of the muscle showing less fat infiltration in the quadriceps in the treated group. I'll show you a picture just now, and it's givinostat. There are currently ongoing studies in Canada for non-ambulant boys. So you see the difference between the two groups at 72 weeks. And so this is a normal cut through the thigh. And these are the quadriceps muscle. So in Duchenne, with time, there is more fat that makes the muscle look wider. So the fat infiltration was significantly less in the givinostat treated group. Another molecule that was very important for all the presenters and I to discuss, because it has a Canadian connection, is SAT-3247. So I'm talking about drug mechanisms, but you cannot talk about drug mechanisms without talking about disease mechanisms. So we've already spoken that dystrophin has a stress, like how to help muscle handle mechanical stress role. It has a role in controlling overactive inflammation in the muscle. But one of the things that drive the pathophysiology of Duchenne muscular dystrophy is also impaired muscle regeneration after injury. So satellite cells are the resident stem cell population of muscle, and satellite cells are not normal in Duchenne muscular dystrophy. So normally, satellite cells, they can divide in a symmetric way or an asymmetric way. I won't go into too much details with this, but asymmetric cell division of satellite cells is really key to have myogenic progenitor cells. These are the cells that will come and repair injured muscle cells. In Duchenne muscular dystrophy, what has been shown, including by many researchers at the Ottawa Research Institute, is reduced asymmetric division. So this leads to impaired muscle repair. So an important point is when we combine efficient Duchenne muscular dystrophy treatment, it's important not to forget about these satellite cells as they play an important role in the Duchenne pathophysiology. SAT-3247 is a small oral molecule developed by Satellos. It acts through inhibition of AAK1, adaptor-associated kinase 1. This is not important to remember, but basically when you inhibit this protein kinase, you lead to a rescue of your asymmetric stem cell division that has been decreased in Duchenne muscular dystrophy. This is again a dystrophin protein independent approach that's suitable for all gene mutations in DMD. So obviously this is a very small and very short study in adults with DMD. It found SAT-3247 to be safe, well tolerated. And although it's a very short study, it's very impressive that, although again, I'm going to say the same thing as Hugh, we have to be very careful when interpreting such small studies. But again, I think we can still be encouraged by the fact that it showed increase in grip strength and even improvement in the predicted forced vital capacity, so a key measure of lung function. That's absolutely inconsistent with the natural history of adults with Duchenne muscular dystrophy. So what's next for the Duchenne muscular dystrophy community in Canada and worldwide? I think that the reason that we've spoken so much about clinical trials and different drug mechanisms is that from what we can see now, in the very short in the short future, there's not going to be one drug that's going to be a cure. So we need to have a great combination of therapies that act on different pathways and on different problems that are part of the pathophysiology of Duchenne muscular dystrophy. Some of these will be dystrophin restoring therapies. So we've learned many lessons. As Hugh mentioned, we've learned that increasing microdystrophin might not automatically lead to clinical improvement. So that's why it's exciting to know that people worldwide are working on systems that might allow us to deliver a more complete version of the dystrophin gene. There are also many studies on looking at better immunosuppressive regimen to decrease the potential adverse events of gene therapies. Again, there are also other next generation gene editing that are on the way. And not to forget the other strategies that are dystrophin independent, anti-inflammation, anti-fibrotic, muscle enhancement, regeneration, and not to forget strategies that act on the satellite cells. And obviously, another very important point to discuss worldwide is how can we get these therapies, once they're approved, quicker to patients? Would it be useful to have newborn screening to be able to start these earlier when the muscle is still relatively in good shape? So lots of things to work on, but we're glad to be there for it. That's all for me. So I want to thank all of you, especially our family. So this is an event that was held at our rehab center last year, where the Guide du jeu vidéo du Québec, so the video game guild of Quebec, came to visit our patients' families and let them try new versions of video games.
Thank you, Dr. Nguyen. Thank you again, Dr. McMillan, Dr. Yaworski. And now we're entering into our Q&A panel. We're glad to have Dr. Campbell here as well. And we thank you all for being experts in supporting these clinical trials. And I should just echo what Dr. Nguyen said. We should be thinking, we are all thinking, patients and families who make courageous decisions to enter into these clinical trials that really help us to better understand the value of these treatments. And really, that actually brings us to our first question, and maybe I can ask you, Dr. Campbell, with PTC recently announcing that it's closing its clinical trial for Duchenne here in Canada, and now this family is sharing that their son, who's a young adult, would not be eligible for many of the trials spoken today. What are your thoughts? Are there opportunities likely to be available in the future?
Yeah, it is a profound disappointment, and I'm, so heartbroken with you for, the fact that PTC Therapeutics is not making the drug available on a compassionate basis for boys who participated in the trial for many years. They are still manufacturing the drug, and it is available in some countries, including England. So I'm really not sure why that decision has been made. I'd obviously encourage everyone to reach out to PTC and speak with their patient relations folks. I can tell you, I've certainly argued against it, all I can say is it just doesn't seem acceptable to me to not make it available, particularly for boys who have been in the clinical trial and given years on this drug. While the company worked its way through, albeit disappointing, regulatory opinions. I will say one thing quickly. The FDA, to my knowledge, has yet to definitively give their opinion on Lauren, unless it's happened in the last couple of weeks. But we do await an opinion from FDA, to my knowledge, and that could really be a game changer for Lauren. But given all the other disappointments around it, I'm not overly optimistic, let's say that. It is challenging for older patients at later stage of Duchenne who are interested to participate in clinical trials because, all the speakers spoke to this, because certain outcome measures need to be measured in a clinical trial to find out or to decide if a drug is effective. Finding those outcome measures in older boys and men who are already quite weak can be a challenge, and that's where that is where drug companies are making decisions about can they run a clinical trial in an older population and have a signal, like have an outcome measure that they can show a difference in. And that's really what the regulatory agencies are looking for. So that's a challenge for our community.
And then several questions about this, which is related to with the Health Canada approved vamorolone adults. So we see an individual saying, I have a 21-year-old, 24, age 40 with Duchenne, individuals saying they've been on it since age 8 in terms of, deflazacort. Vamorolone, is that likely to be used in adults, or is it primarily for children who receive a new diagnosis of Duchenne?
I can speak to that. And sorry, I should have mentioned this in my talk. So although it was recently Health Canada approved, it's not quite commercially available yet for anyone. And that's just because it takes time for the provincial governing bodies to make their decisions about how things are going to be reimbursed. And of course, for the company to make a certain amount of the medication. And so we of course had a lot of people asking, can we switch it right away? So even for younger boys, it's not something that we have the capacity to switch to just yet. In my opinion, for older adults, I think there's probably less benefit of switching to vamorolone. And the reason I say that is because of what Dr. Nguyen mentioned. The really big benefits of vamorolone are on that maintained height and some of those vertebral fractures. And so I think obviously as an adult, we wouldn't expect you to grow any further. Potentially there's some added benefit from bone fractures or vertebral fractures that could be helpful. But in my experience, the weight gain changes, the behavior changes have been less striking. And so I think you're going to see less people switching if that's even an option from a reimbursement perspective.
And since we're on vamorolone, the other question is, and maybe I can start by asking you, Dr. Campbell, which is to say, when will vamorolone be considered standard of care? Because sometimes with clinical trial criteria, the inclusionary criteria, it doesn't include vamorolone as a standard of care. And so this is why they don't think they can switch over. What are your thoughts around that?
Yeah, that is changing. We are seeing amendments go through for current clinical trials to be able to enroll boys on vamorolone. Once something becomes widely available in the U.S., we usually see the clinical trials, which vamorolone is now. We usually see the clinical trials shifting. Generally, for a clinical trial, if you're following the standard of care, you should be eligible to go in a clinical trial. So I don't think that will be like an ongoing barrier as vamorolone becomes more available. Will it become the standard of care? I don't know about that. I think what it does do, and what we all want in every area of medicine, I think, and with our health, is we want choice, and we want the ability to make informed choices that work best for each individual based on what they're experiencing. And so if you're someone who struggle with weight gain or bone fracture or something like that, maybe vamorolone is something that you would want to choose, and you'd work with your healthcare provider to make that choice. But of course, we can't deny that prednisone and deflazacort have been shown over and over in many studies around the world to be very effective too. So there may be families that choose that route until there's longer term data on vamorolone. So I think it's about choice personally, and being able to tailor management to what's most meaningful for the family and the patient with DMD.
Since we're on the topic of glucose corticoids, the question is whether you're seeing within your patients more of a use of GLP-1. So the specific comment is on Ozempic and Wegovy in managing weight gain. Have you been seeing that at all? Dr. McMillan, could I ask this question over to you?
Yeah, no, absolutely. We've had a lot of people ask about it, and there have been some very preliminary discussions with endocrinology. What I can say is we don't recommend it first line. We'll typically use metformin as a weight stabilizing drug first. Sometimes there can be other medications that might be an option. If, for example, for individuals who have ADHD, if they're on Vyvanse, that sometimes can have a pretty significant impact if there's some compulsive eating that might also be contributing to weight gain. So we do try to use medications like that earlier. The one theoretical concern I have about Ozempic and GLP-1 inhibitors is they certainly are very effective at causing individuals to lose fat. But in individuals who don't have muscle disease, there's also a risk that they will lose muscle. So there's a theoretical concern for someone who has a muscular dystrophy that if they're losing fat and they're losing muscle, that potentially could benefit with the weight loss, but potentially accelerate the progression of the disease. We don't know that yet, but it's just a cautionary tale to be very wary of. And if it's being considered, to make sure that the protein intake is optimized. One last piece I would say about that is GLP-1 inhibitors have been associated with significant constipation, and that already is a problem for our population. So I think it could be considered, but very, very cautiously.
Thank you. All right, we'll go to the last question, which is around the Satellos trial. Dr. Nguyen, you mentioned this. Has the Satellos study in children started anywhere in the world?
I'm hoping Dr. McMillan will help me with this, given that he's from Ottawa, not to my knowledge.
It's moving ahead fairly quickly. Ottawa will be a site for the Satellos trial, and we're hopeful that we'll begin recruiting people approximately late February, March is our hope. But it's still moving through ethics and approval right now. I don't think that anyone's recruiting. I know there's sites in the US that are not recruiting yet. Australia might have started. They always are a little fast, and the European sites I don't believe are yet. So it's but it'll move ahead within the next few months, I believe. I'm not sure if you want to add anything, Amanda, but I think that's yeah.
So on that note, thank you all so much. That was a really clear presentation. Aside from the questions, so many comments saying this is one of the first sessions where your use of plain language, the analogy, the shock absorber, the fat cat, those really resonated with today's audience, which includes clinicians, but families and patients as well. So thank you all so much for preparing such clear talks and supporting our question and answer panel. This recording will be available on MDC's YouTube channel. That is important because there was a lot of information. So please replay, re-listen, and reach out to us if you have any questions. So thank you again, Dr. Nguyen, Dr. McMillan, Dr. Campbell, and Dr. Yaworski. Thanks everyone for joining this evening.